Welcome to Dr. Balaga's God Knowledge Doc podcast, your quick dive into the latest medical breakthroughs to keep you ahead of the curve. Let's get started. Today is September 5th, 2025. This video is in a JAMA article published online August 31st, 2025, titled FFR Fractional Flow Reserve Guided Complete versus Culprit Revascularization in NSTEMI and multivessel disease, the SLIM randomized clinical trial. Multivessel coronary artery disease is present in greater than 50% of patients with non-ST elevation MI or NSTEMI and is linked to poor outcomes. Prior data in this group were limited, often observational, and lacked physiologic guidance like FFR or fractional flow reserve. To compare FFR-guided complete revascularization versus culprit-only revascularization during index procedure in NSTEMI patients with multivessel disease. Keeping this objective in mind, the study design was an international multi-center prospective randomized controlled trials at 9 European hospitals. 478 patients, mean age 65.9 years, 72.9% were men, randomized 1:1 to FFR-guided complete revascularization, N equal to 240, versus culprit only PCI, N 238. Follow-up 1 year. Primary endpoint adjudicated by a blinded committee. Stats: Cox proportional hazards, Kaplan-Meier, and log rank tests with SPSS. Hazard ratio with 95%. Confidence interval was reported. P-value less than 0.05 was significant. What did they find? Composite of all-cause mortality, non-fatal MI, stroke, and any revascularization was lower in the FFR-guided group, 5.5% versus 13.6, p-value 0.003. Secondary outcomes: any revascularization, 3% versus 11.5%, p-value 0.001. Net adverse events, 6.3% versus 15.3%, p-value 0.002, both significantly reduced. No difference in mortality or stroke. Limitations: open label design, underpowered for individual outcome components, lack of generalizability due to exclusion criteria. And there's potential selection bias. Key takeaway: FFR guided complete revascularization during index procedure significantly reduces composite adverse events in NSTEMI with multivessel disease. Clinical pearls of the from the SLIM trial: FFR equal to or less than 0.80 remains a reliable marker to guide PCI in NSTEMI with multivessel disease. Completeness of revascularization matters, especially during index procedure. Reduction in revascularization appears to be the primary driver of benefit. FFR-guided strategy avoids unnecessary PCI in angiographically intermediate lesions. Despite high contrast radiation load, no significant rise in complications with complete strategy. Eponyms: synergy between PCI with taxis and cardiac surgery. Anatomical complexity measure. TIMI flow is grading of coronary blood flow pre and post PCI. Gray score, global registry of ACS events, prognostic tool for mortality in ACS. Key articles: any JAMA article, they introduced FFR in 1996, cornerstone for physiology-based revascularization. Roxana Miran et al. Defined bark bleeding criteria used for safety endpoint adjudication. An interesting infographic from JAMA. The question was in the study: is FFR-guided complete revascularization superior to culprit-only revascularization in NSTEMI and multivessel disease? And the conclusion was, among patients who underwent successful PCI of the culprit lesion, FFR-guided complete revascularization during the index procedure resulted in a significant reduction in composite outcome. If you enjoyed this episode, share it with your colleagues. When we change how we see disease, we change how we shape lives. Until next time, stay curious, stay compassionate, and keep seeking wisdom. Podcast brought to you by Master MedFacts at mastermedfacts.com.